Hello everyone, my name is Eric Chow from the Melbourne State Job Centre in Australia. Today I would like to present the finding from a recent study that we conducted examining the HPV prevalence among young and bisexual men before and after the introduction of the gender-neutral vaccination program in Australia. Here are my disclosure. The HYPER 2 and HYPER 1 study were funded by Merck and also partly funded by the Australian Government Department of Health. Before I start, I would like to give you a brief introduction of the HPV vaccination program in Australia. The program started in 2007 with a school-based program for girls aged 12 to 13 years and also with a catch-up program for girls aged up to 26 years. And it was expanded to include boys for age 12 to 13 years in 2013 and also with a 2 years catch-up program for boys aged up to 15 years old. There was some time-limited catch-up program for men who possessed men in 2017 in some Australian states. Between 2007 and 2017, 3 doses quadrivalent vaccine were used for the school-based program. And in 2018, we changed to 2 doses monovalent vaccine schedule for the school-based program. There have been lots of studies showing large reduction in HPV prevalence and genital warts among female and heterosexual males after the introduction of the female-only vaccination program. But MSM are less likely to receive her protection from the female vaccination program compared to heterosexual males because of their sexual practice. MSM, particularly young MSM, have a high HPV prevalence and also have a very high prevalence in the anus. Past study in Australia showing that the prevalence of quadrivalent type in the anus ranging from 20% to 43%. The differences of prevalence between studies were mainly due to the different sensitivity of the genotype assay. However, there's no study examining the impact of MSM from a universal school-based HPV vaccination program. The aim of this study was to examine the HPV prevalence among young men obsessed with men who were age eligible for vaccination in the universal or gender-neutral school-based program in Australia. The 2 HYPER study was repeat cross-sectional study. Both studies used the same recruitment methodology. We recruit 200 gay and bisexual men aged 16 to 20 years old in each cohort. The HYPER 1 study was published in the Journal of Infectious Disease. It was conducted in 2010 to 2012, which was before the implementation of the gender-neutral vaccination program. And the HYPER 2 study was conducted in 2017 and 2018. Comparing between HYPER 1 and HYPER 2, we keep this methodology relatively similar. We recruit 200 gay and bisexual men aged 16 to 20 years old. We recruited men from sexual clinic and the community. We collect samples including all rings, penile swabs, anal swabs, and blood. There was a slightly different in the use of the genotype assay, but I will come back to this point later. In HYPER 1, all men were not eligible for the school-based vaccination program. However, in HYPER 2, all men were eligible for the school-based vaccination program. The study procedure were all conducted at the Melbourne State Job Centre. We also recruit men from the community, including university, social media, and dating apps. In terms of specimen, we asked the participant to rinse and gargle 10 ml of cell line for 20 seconds. We also asked the participant to self-collect the penile swab after using the paper emery board. We also have given them an instruction sheet on how to collect the penile swab. We have also have a clinician-collected anal swab, and also blood was collected for HPV serology. In this presentation, I'm going to present the results from all race penile swab, anal swab only. And all the samples were tested and genotyped at the World Women's Hospital laboratory using the STDP2020 assay. And the blood was sent to the US for HPV serology. So coming back to the genotype assay, the linear array watch assay was used in the HARBOR-1 study, and in HARBOR-2 study, we used the STDP2020 assay, which has a slightly better sensitivity compared to linear array. With different sensitivity of the assay, we test all HARBOR-1 sample using the STDP2020 assay. So today, the result I'm going to present were all tested by the STDP2020 assay. This graph shows the proportion of accessible specimen in the anal, penile, and oral specimen. The proportion of accessible specimen were relatively similar in both cohorts. The demographic characteristics were also very similar between HARBOR-1 and HARBOR-2, except in HARBOR-2, more men report circumcision compared to HARBOR-1 study. And also there were 75% of men in HARBOR-2 received at least one dose of HPV vaccine compared to 0% in HARBOR-1. By looking at the number of lifetime male partners, the number of partners for receptive, insertive, oral, and anal sex were relatively similar between the two cohorts and did not differ significantly. However, when we look at sex with female, we find that less men report having sex with female in the HARBOR-2 study compared to HARBOR-1. Here shows the prevalence for anal HPV. So clearly we can see that the anal HPV quadrivalent type reduced from 28% to 7% after the introduction of gender-neutral vaccination program. And I would like to highlight anal HPV-16, which caused most of the anal cancer, which dropped from 9% to 3%. Similarly, we saw a reduction in penile quadrivalent type from 12% to 6%, as well as the oral rinse samples from 4% to 1% for the quadrivalent type. We have also adjusted the prevalence ratio for age, circumcision, and sex with female. There was a 76% reduction in anal quadrivalent HPV type, a 52% reduction in quadrivalent penile HPV type, and also a 90% reduction in the quadrivalent genotype in the oral rinse samples. There was significant reduction in anal low-risk type 6 and 11, as well as the high-risk type 16 and 18. But we did not see a significant reduction in high-risk 16 and 18 type in the penile and oral specimen. To conclude, this was the first study examining the impact of the school-based male program with high vaccination coverage. There was significant reduction in vaccine-preventable quadrivalent genotypes among men in the post-vaccination cohort. We also saw a 70% reduction in the prevalence of anal HPV-16, which was the genotype most commonly linked with anal cancer. This reduction was likely due to the vaccination program because the anal sexual practice did not change between two cohorts. And this suggests that the school-based program for boys can actually lead to reduction in incidence of anal cancer. Although the prevalence of HPV-16 and 18 in the penis and oral cavities was lower in the post-vaccination cohort, there was no significant reduction between the two cohorts, possibly due to the limited sample size. And I would like to thank everyone who helped in both HARBOR-1 and HARBOR-2 studies. The finding of these studies has been recently accepted for publication in the Lancet Infectious Disease. Thank you.
Hi everyone, I'm Karen Nicosia. And I'm Megan Stafford.
And we work for the Ohio Department of Health's STI and viral hepatitis prevention program. 2 years ago, I sat at this conference with my supervisor, Lori Rickert, intimidated by how together every other program appeared. Lori started in her position a few months prior, and I had been working for ODH for about 2 weeks. There we met our new project officer, Brittany Johnson, who gave us a pep talk and said we'd be in the position to present at the next one. We didn't believe her, but here we are. Our program has undergone a lot of change in the last 18 months, and we would like to thank the following people for specifically helping us work through our analysis of our STI testing program. And for a visual, that's Brittany, myself, Megan, and Lori in front of a great piece of ODH peach-themed art. Our STI screening program was based on the Infertility Prevention Project begun in the 1980s. It provided free gonorrhea and chlamydia testing through CDD for anyone under 29, anyone who was a contact to someone with gonorrhea or chlamydia, or anyone with signs and symptoms. Approximately 120 sites participated in the program, costing over $600,000 a year. This new Peach grant provided us an opportunity, or rather required us, to examine the efficiency and efficacy of this program, as it was such a large portion of our budget. Because of this, we decided to focus our targeted evaluation plan on our testing program. Our TEP has 4 components: create a program logic model, analyze payment protocols and workflows, conduct a survey of the program participants' needs and perceptions, and finally, conduct an impact analysis. So first we did a logic model, and who doesn't love a good logic model? For the purpose of this project, we used a very simple template provided by the CDC. Through this process, we mapped out all of the intricacies and details of the program. Our main finding was that our desired program outcomes are not directly connected to the activities and outputs of specifically the screening program.
The next step of our TEP was an analysis of our payment protocols and workflows. With this, we were hoping to develop a more robust idea of what was actually happening in our program. It had been kind of chugging along for years with a relatively hands-off management approach. So the questions we were asking at this step were essentially, is the program achieving the goals it was originally created to achieve? Is the program achieving meaningful current programmatic goals? And what is it costing us in time, effort, and money to run this program? So we analyzed the demographics data that our testing sites were collecting and the invoices from CDD, and with 2 major findings. First, we were paying for tests that we weren't supposed to be covering. For example, sometimes we were charged for syphilis tests, though the program was only supposed to be for chlamydia and gonorrhea. We were also sometimes paying for tests for people who didn't meet our eligibility requirements. That was generally people who were outside of our age range. Also, in March of 2019, a court case was decided allowing our legislature to end all funding to the largest utilizer of our program throughout the state. So our other sites didn't see an uptick in the numbers of tests they were performing. So we also know that potential patients were not being redirected to participating sites, which means we lost about over 60% of our reach through that court decision. The next step in our TEP was a survey of all of our program participants. To gauge their experience with the program, we asked questions about their perceived need for safety net programs, for STI testing and medications, whether they understood our eligibility criteria, and what testing and medication needs the program was or was not fulfilling. First, I'll just note that not everyone responded to every question, so the totals on the slide reflect the number of people who responded to each individual question. And as you can see on the slide, the majority of respondents indicated that they did need safety net programs to meet patient demand for STI testing and medication, but also that many of them were not taking advantage of other funding sources that were available to them. For example, 13 of 70 respondents reported only using one other funding source to pay for testing, often their general revenue, and only 26 of 70 reported offering Medicaid enrollment and then backbilling Medicaid for the services they provided, which was another thing we really encouraged our sites to do. So the final step of our TEP was an effort to understand the outcomes of the program and what would be the impact if we decided to end it. In other words, is the juice worth the squeeze? So the first step of that was to look at our program outcome data, including testing positivity rates. So here we have our program's positivity rates for chlamydia. And as I mentioned a couple slides ago, our eligibility criteria were often not adhered to, and you can see that our positivity rate wasn't especially high. You'll also notice that it seemed to be getting lower across the years from 2015, which is blue here. Also, I'm showing the data monthly because at the beginning of our 2019 contracts, which started in the summer, we tried to reinforce stricter eligibility criteria to focus more on our priority populations, which worked for about a month, where positivity rates increased dramatically, but afterwards immediately returned to their previous lower rate. And on the right here, we have a map of statewide chlamydia rates by county overlaid with our screening sites. Because sites were added as requested throughout the program's life, locations weren't planned based on morbidity rates or resource needs. So you'll see some low morbidity counties with multiple testing sites or higher morbidity counties with very few sites. You'll also see some overall regions have higher concentrations of sites, with other regions with almost no testing sites. And then here you'll see the same data for our gonorrhea testing, which look pretty similar. And so both of these really emphasize for us that we weren't necessarily responding to need. We might have been fulfilling some needs throughout the state, but not in a purposeful, effective, or fair way. So the next step then was to understand the impact of potentially ending the program. Obviously, ending the program would be a big hit for our biggest utilizers, two of which were a local health department and a university student health center. But on the other side of that equation, we noted that we were spending a large portion of our budget on a program that didn't meet our state's needs and was not very efficient. So the average monthly cost per site wouldn't be that much for sites to absorb, but added up to a lot for us to fund. And the cost per positive wasn't effective. And this on the slide is only the invoiced cost and doesn't include the costs of managing the program on our side. So those things add up to a potential huge cost savings for us that could be redirected into more purposeful programming. So the conclusion of our TEP activities were that the screen program was not being used as intended, was not well matched with community needs across the state, and wasn't a good value for the budget line.
It's easy to end a program, but it takes a lot of intentionality to end one constructively. Our main concern was leaving our constituents without services they need. We worked with CDD to offer special pricing for public health institutions, and we organized with internal partners, such as our Title X and reproductive health programs, to see what gaps they were able to fill. We also asked our Ryan White Part B program to place STI testing and treatment on their fee schedule so that those services are covered for people living with HIV under 500% of the federal poverty level. Most importantly, we provided substantial notice to all of our sites explaining our decision and substantial TA to help with the transition and implement third-party billing and sliding fee scales. We learned that equal time should be spent planning and implementing program changes, and I really think that helped our transition run smoothly. Once we freed up those dollars, we were able to reallocate them in a more closely aligned way with PEACH objectives and community need. We added 3 new positions, 2 dedicated to education and 1 a program scientist. We were able to tweak our funding formula for our subrecipients to align our funding more with the burden of infection that each region faces. That resulted in being able to increase the budgets of our rural areas and requiring our subrecipients to conduct some extra activities like social media outreach, community engagement, fund STI testing themselves, which lets them determine for themselves what tests to cover and for what populations, and to start ramping up congenital syphilis review boards. On our horizon is an initiative to focus on quality improvement grants, funding small pilots for innovative STI prevention and community engagement work. We really are a completely different program than when Lori and I sat at this conference 2 years ago. We're now adapting and are able to address the needs of our subrecipients and our communities. We're moving towards intentional and deliberate program activities with a clear vision for the future. Here's our contact info in case you're interested in hearing more about our program or our process or have any questions. And thanks for listening to us today.
Automating provider reporting of chlamydia and gonorrhea to public health in Illinois and Oregon clinics. My name is G. Oakley. I'm a research associate at OCHIN and a project manager for this project. I'm very grateful for this opportunity to share our work with you on behalf of our project team. I'm also joined by Jonathan Todd, who is an infectious disease epidemiologist and a principal investigator on this project. He'll be sharing the summary of our preliminary findings during this presentation here shortly. I'd also like to thank many of the co-authors who contributed to this work across the 2 project sites in both Illinois and Oregon. Our OCHIN team worked closely with the Oregon Health Authority and our project supporters from both the Public Health Informatics Institute and the CDC to implement this project in Oregon. From the Illinois site, the Alliance of Chicago team worked closely with their public health department, Illinois Department of Public Health, alongside of PHII and CDC to implement the similar pilot project in their Illinois site. Before we get into the specific details of our project, I just wanted to add a quick context here that chlamydia and gonorrhea accounts for a large proportion of reportable disease burden, especially here in Oregon, which is why automating public health reporting from public providers' electronic health records for these 2 conditions warrant a special attention. To illustrate the predominant data transactions that support public health reporting for chlamydia and gonorrhea, among other conditions, we have illustrated a couple of diagrams here to show how electronic case reporting for STDs are currently set up, and it is actually in practice. Currently, providers can report STD cases to their local authorities in various formats. It does include faxing and manual web entry forms, which can be seen as burdensome for many of the clinic staff. They reach out to the clinician to obtain those extra information, but sometimes even reaching out can be challenging because so many of the electronic lab reports may also lack the clinician's contact information. What we are envisioning is a future state where reporting is less burdensome for both clinical and public health stakeholders. Automating case reporting, known commonly as electronic case reporting or ECR, stands to improve data quality and timeliness, all while leveraging the data that's already in the electronic health record. This automation stands to decrease provider reporting burden and supplement the data public agencies already receive via laboratory reporting. And it can also provide public health departments with important data such as patient demographics, contact, and treatment information in a much standardized format. So in our project, our goal was to increase standards-based electronic case reporting of chlamydia and gonorrhea between healthcare providers and their jurisdictional public health agencies. Alliance Chicago and OCHIN are the 2 health center controlled networks that have separately incorporated this process into their existing information systems. For our project, we've integrated predefined case reporting criteria within our electronic health records and interface engines to determine if a given patient encounter is has met the public health reporting requirements for chlamydia and gonorrhea. Each group then determined at what points in the existing workflows to evaluate these criteria against the patient's encounter data, which included, for example, when the provider closed the encounter, when a lab result was received, or when a lab result was manually entered into the EHR. And once the appropriate encounters are identified, the encounters then are summarized with the case report data elements. In other words, it's not the entire patient encounter that is sent to public health, but rather a subset of data that is required for public health to review and to further investigate as needed. This slide illustrates the STI case detection logic that we've used and created with input from state and local surveillance and informatics subject matter experts. The case detection is based on patients' encounter data in the provider's electronic health records. And if the logic is satisfied for a particular patient encounter, then the system will create and send the case report on to public health department. The model here, the model value sets use codes from standard health IT vocabularies, including ICD-10, LOINC codes, and SNOMED codes. However, those standard codes have to be mapped based on what data types data types and codes are available in the electronic health records. While the initial model logic have created 3 different scenarios, as you'll see here, the 2 electronic health records used in these pilot studies only contain codes that reflected in 2 of the 3 scenarios. The first scenario reflects that if a patient's diagnosis is in a predefined list of codes for either chlamydia or gonorrhea, the logic is satisfied and a case report is sent. The third scenario requires that a patient's record must include both a code for a lab test that was performed and a code for a lab result as well. In this slide, you'll see the contents of case reports as defined by HELP Level 7, which is a standards development organization for health information and is referred to as electronic initial case report, or EICR. These case reports are batched together and sent from the EHR to public health on a schedule consistent with jurisdictional reporting guidelines, though they can be sent real time as needed. The screenshot on the left is the paper case report that are typically faxed from a provider's office to the Oregon Health Authority. And the screenshot on the right illustrates some of the key data elements contained in these electronic initial case reports, such as patient name, date of birth, reasons for their visit, problems, lab results, medications, and other types of medication history. And in Oregon, OCHIN and OHA uses secure file transfer protocol to exchange these batches of electronic initial case reports. And then once received, OHA will map the EICR data elements to their existing surveillance system, and then make the reports viewable to select system users. This workflow is a high-level overview of electronic case reporting that was implemented in Oregon site. OCHIN has recruited 3 of our member clinics to pilot this approach for their chlamydia and gonorrhea reporting. And how it works is that once the patient's encounter is entered into OCHIN Epic, the EHR will register their clinical updates. Then an STI case detection logic will be executed upon a close of encounter, or when a result is sent or manually entered into the electronic health record. And then a case report will be populated with the relevant patient data, and then a case report will be assembled to be sent over to OHA. And once OHA receives the case reports, then it gets inserted into their surveillance system. An acknowledgement message confirming the receipt of these electronic health case reports will be sent to FTP server. Then OHA would also go through the deep duplication process and consolidate the data sources in their surveillance system, and assess if a patient has received STI diagnosis and conduct further case investigation as needed. I'm going to hand this presentation over to Jonathan, who will share some of our preliminary findings from the project.
Thank you, G. So OCHIN and the OHA team separately evaluated the case reports that were generated from the study after 15 weeks of our intervention period. We've highlighted here some of the areas we decided to review in our summary of findings that we'll go through in our next slides, including case detection frequency, case report completeness, ECR throughput, and a comparison of EICRs and ELRs. Here we are showing the breakdown of the 2 different scenarios, the first being a diagnosis code, and the third scenario involving a lab test performed and a lab result indicating presence of the relevant RNA. Out of 154 detected chlamydia codes, 57 resulted from a diagnosis, while 97 resulted from a lab test combination. A similar trend appeared with gonorrhea tests, with 44% of the 232 detected gonorrhea codes resulting from a diagnosis code. The completeness of the case report is demonstrated here. As you can see, several of the relevant variables are found in all the EICRs. Some are less than 100%, it sort of just varies here, but definitely have 100% completeness in many of these variables. Here we talk about the ECR throughput. 328 out of 365 EICRs, or 90% of them received, were found to meet OHA's case definition. The most common reason that an EICR did not meet the case definition was the lack of positive lab results, meaning no lab results were received by any mechanism. We had 184 unique patients with a valid EICR during the study period and 196 unique cases. The mean number of EICRs for chlamydia was 1.5. For gonorrhea, it was slightly higher, 1.9. Here we talk the comparison of EICRs and ELRs for chlamydia. The Orpheus surveillance system captured 131 chlamydia cases across the 3 participating clinics during the study period. At least one EICR was associated with 72% of the cases. 8 chlamydia cases had neither an EICR nor an ELR attached, but were reported via another mechanism, such as the electronic provider morbidity report. An EICR case detection logic identified 6 additional chlamydia cases not reported via ELR. The Orpheus surveillance system captured 117 gonorrhea cases across the 3 participating clinics. At least one EICR was associated with 88% of the cases. 7 gonorrhea cases had neither an EICR nor an ELR attached, but were reported via another mechanism. And the EICR case detection logic identified 15 additional gonorrhea cases not reported via ELR. Here we have a comparison of the completeness of the data included between the EICR and the ELR. Of note is the increased proportion of race and ethnicity data captured by the EICR method. In general, the EICR method provides much more complete report data than does the ELR. Here we list facilitating factors, barriers, and some future recommendations for additional work based upon this project. Of note, we were fortunate to work with skilled, motivated clinical partners well-versed in STI reporting. We did learn that obtaining approval for data exchange between the health organization and the public health authority was not simple and required considerable time. And we believe that an emphasis on user education, including additional context for users on the benefits of EICRs, will be beneficial in future implementations of the EICR approach. All in all, we found that ECR added value and have determined to maintain the data feed between the clinics and the Oregon Health Authority. That said, there is opportunity for improvement as support becomes more available following the COVID-19 pandemic. We were able to leverage learnings from this project to quickly stand up electronic case reporting during the pandemic among OCHAN clinics. Thank you very much.
Hello, my name is Suzanne Grieve, and I am a faculty research associate in the Center for Child and Community Health Research at the Johns Hopkins School of Medicine. Today I will be presenting on building trust to improve engagement and impact of HIV/STI research with Black sexual minority men. This research comes from the formative stage of a larger study called USHINE, or Understanding Sexual Health in Networks. The formative phase of the project aimed to foster engagement with Black sexual minority men to inform the larger study. I will briefly provide some background regarding challenges to conducting research with Black sexual minority men, describe the formative study objective, methods, and results, and present some of the actionable recommendations that emerged. I will also briefly share about our Community Advisory Board. Engagement with sexual minority communities is crucial in addressing HIV and STI disparities. However, numerous studies have found that Black or African American communities, including Black sexual minority men, have high levels of medical and research mistrust. As a result, they have historically been difficult to enroll and retain in research studies. Additionally, Black sexual minority men have reported feeling overstudied in HIV and STI research and have expressed doubts regarding the impact of these studies on their sexual health. Instead, they have expressed concerns that the abundance of research further stigmatizes their communities. Thus, the goal of the current research was to use qualitative methods to identify community-developed strategies that may enhance community engagement in research with Black sexual minority men and inform current and future HIV and STI research efforts. 7 focus groups were conducted in Baltimore, Maryland between March and May 2018. Cisgender Black men were eligible to participate in the focus groups if they were between 18 and 45 years of age, reported sex with a man in the past 90 days, and lived in Baltimore City. Participants were recruited via 3 methods: from previous research studies, from Baltimore City Health Department disease intervention specialists' routine partner service interviews, and from recruitment flyers that were posted at the 2 publicly funded sexual health clinics and the Pride Center of Maryland. The focus groups were facilitated by Black male research team members and lasted approximately 1.5 to 2 hours. They were audio taped with participant permission, and transcriptions of these sessions were then analyzed by 3 team members through an iterative thematic constant comparison process informed by grounded theory. This table provides some basic demographic information for our study participants. As you can see, the men had a mean age of 27 years. The majority identified as homosexual, gay, or same-gender loving, and had attended at least some college. Participants discussed the extent to which HIV and STI research is focused on Black sexual minority men, and many concerns about research were discussed. However, participants also saw value in research, acknowledging that research findings can lead to improvements in health and can aid in society's understanding of and response to challenges faced by sexual minorities. To promote the benefits of research, participants identified strategies to address their concerns about research and increase its values for their communities. 4 distinct themes emerged that centered on the importance of trust building through community engagement: authentic engagement with the community, increased transparency of the research process, capacity building of research staff from the community, and a balance of research and action. The first theme focused on engaging authentically with the community of interest. As one participant stated, that's the biggest one. It's got to be caring. If it's not genuine, don't do it. Participants felt that this authentic engagement should be consistent and occur throughout the research process, but emphasized early relationship and trust building. Importantly, participants discussed wanting engagement with the researchers, including principal investigators, and not just the staff, to remove an us versus them mentality. The second theme focused on increasing transparency of the research process. This included transparency of research protections and the IRB process, as well as transparency regarding the researchers themselves, particularly the principal investigators. This quote from a participant demonstrates this. Sharing the point of what you went through. How did they get to the point to even want to research that? What problems with the numbers do they see? Why do they want to get this data? The third theme relates to capacity building among research staff hired from the community. Many studies hire community members as staff to help with recruitment, for example, and the participants appreciated this, but felt that these opportunities should provide more than temporary employment. One participant talked about this, saying, "So the research provides positions for people, but it doesn't provide with much advancement. It gets people play and employed, but what about the next steps? Like, how do you prepare them for the next?" Additional opportunities should be provided to these staff members to promote their continued advancement beyond the study and grant period. The fourth theme is balancing research and action. Noted one participant, "They offer you these little stipends and it's cute. But what are you really giving back once it's completed?" Participants felt researchers should provide study findings back to the community as well as to local providers who often see community members but may not have the resources to stay up to date on cutting-edge science. Additionally, participants wanted more action focused on upstream social determinants of health, as this is what they believed would ultimately benefit their community's sexual health outcomes. A number of actionable recommendations emerged from these focus group findings, some of which are included here. First, researchers must authentically engage in trusted spaces with trusted partners. It is not enough to simply work behind the scenes with community partners. Researchers themselves should be visible in the communities within which they work and allow for transparency regarding their motivations and goals. Researchers should also provide opportunities for community members to learn about the research process and the rules governing ethical conduct and oversight. As one example, researchers can support events where previous research participants, for example, provide their experiences alongside of researchers who share about the IRB review and other safety procedures put in place for participants. Next, hire and importantly, invest in research staff from the community. Value their knowledge and expertise and support their continued professional growth so that when the study ends, they may have to look for new opportunities, they are in a better position than when they started. Work with community members to increase the shareback of study findings and benefits to participants and community members. And finally, as researchers and public health professionals, we must continue to expand our research and programs to address upstream social determinants of health. Following the focus group discussions, participants were invited to join a community advisory board for the larger UShine study. We have continued to work with 6 CAB members over the past 2 years through monthly meetings. This group has worked with the research team to engage Black sexual minority communities in authentic ways not solely focused on research. They have provided feedback on the UShine study, and they have created and implemented a community dissemination plan. In conclusion, researcher relationship and trust-building efforts within the broader communities within which they work should be ongoing and should not only be connected to the research. Importantly, though, our CAB has emphasized that researchers need to be respectful of safe spaces for sexual minority groups and be mindful regarding their participation in those spaces. By building trusting relationships within these communities, researchers can learn how best to engage and support them. I would like to acknowledge and give thanks to the study team, partners, and funders. This work is funded as part of a cooperative agreement between the CDC, Baltimore City Health Department, and the Johns Hopkins University, and has been possible only due to the contributions of so many talented people. Thank you for listening to my presentation, and please feel free to reach out to me at sgreeb1@jhmi.edu. Thank you.